Hello everyone. I welcome you all to my daily quiz discussion on the Telegram. So today is the medicine challenge day 5. So until day 4 we have finished the connective tissue disorders, and from today I have started with the cardiology sessions. So today's medicine challenge was the topics related to the coronary artery disease or ischemic heart disease and the valvular heart diseases. So now let me start with the discussion. So the first question in the medicine challenge was, the flipping pattern is best explained by LDH1 more than LDH2, second option LDH2 more than LDH1, then third option LDH2 more than LDH3, fourth option LDH3 more than that of the LDH2. Now first of all, let me tell you what is a normal situation. The normal pattern of the LDH1 and as well as the LDH2 is, LDH2 will be much more than compared to that of the LDH1. Now where is this LDH2 present? The LDH2, it is present in the serum, whereas you take the LDH1, it is present in the heart and as well as the red blood cells. So the normal pattern is LDH2 more than that of the LDH1. Now, and this is the image, right, where the LDH2 will be more than compared to that of the LDH1 normal. But what do you understand by the word the flipping pattern? The flipping pattern means the LDH1 will be much more than compared to that of the LDH2. Now why does this occur? Let me tell you. So this will occur in cases of the myocardial infarction. Whenever there is a myocardial infarction, the damaged myocytes, right, the damaged myocytes will cause the release of the LDH1, right, will cause the release of LDH1 in the bloodstream, resulting in the LDH1 value in serum being more than that of the LDH2. Okay, because more and more LDH1 will be released from the myocytes, so LDH1 value becomes much more than compared to that of the LDH2 which is present in the serum, and this is what is called as the flipping effect. Now this LDH, that is lactate dehydrogenase, it is currently used as a tumor marker in certain malignancies. Like example, yes, you see this slide, this is very important. So the LDH used as a tumor marker in case of the lymphoma, Ewing sarcoma, hepatitis, and as well as the hemolytic anemia. Now this LDH, lactate dehydrogenase, it is present in the form of isoenzymes. What are isoenzymes? They are the multiple enzymes, that is isomer of the enzymes, and there are totally 5 isoenzymes of the lactate dehydrogenase, out of which you take LDH1, it is present in the RBC as well as in the brain. LDH2 is present in the reticuloendothelial system. LDH3 is in the lungs, LDH4 in the kidney, placenta and pancreas, and LDH5 that is in the liver and as well as striated muscle. Okay, so this is about the LDH. So what is the normal pattern of the LDH? LDH2 is much more than that of the LDH1. But what happens in case of myocardial infarction? There will be flipping effect where LDH1 will be more than that of the LDH2. Now we'll move on to the second question. Right. So which among the following endothelin is involved in myocardial infarction? That is endothelin 1, 2, 3 and as well as 4. The one which is involved in myocardial infarction is endothelin 1. So endothelin 1, why is it involved in myocardial infarction, is because endothelin 1, it is a potent vasoconstrictor. Because it is a potent vasoconstrictor, due to excessive vasoconstriction, the coronaries will not be able to supply the blood to the myocardium, resulting in the myocardial ischemia and as well as the ventricular dysfunction. So the answer is A. Now you take the next question. So elevated triglycerides and decreased HDL is seen in smokers, alcoholics, athletes and diabetes or diabetics. So most common form of dyslipidemia in case of the diabetics will be increase in the triglycerides and along with that decrease in the HDL, and that will contribute to the atherosclerosis, resulting in the coronary artery disease or the cerebrovascular accidents. So that will be the effect of dyslipidemia in patients with the diabetes. Next question. So which is the best way to differentiate the stable angina and non-ST elevation MI, right? So you take the clinical scenarios like non-ST elevation MI and as well as the ST elevation MI. They come under clinical entity called the infarction, whereas you take the stable angina, it comes under clinical entity that is ischemia, right? That is ischemia. So now how is that you will be able to differentiate ischemia from infarction? That is by the cardiac biomarker. Cardiac biomarkers will be elevated in case of the non-ST elevation MI, whereas the cardiac biomarkers will remain normal in patients with the stable angina. So that is how you will be able to differentiate stable angina from non-ST elevation MI. And you take the ECG. ECG, in both of them, there can be non-specific STT changes. So ST segment depression can be there even in case of stable angina and as well as non-ST elevation MI. So based on ECG, you will not be able to differentiate stable angina from NSTEMI. And transthoracic echocardiography. So in case of non-ST elevation MI, it is not mandatory that there should be hypokinesia, right? It is not must. So even your transthoracic echocardiography will not be able to differentiate stable angina from NSTEMI. And multi-gated acquisition scan, that is MUGA scan, that is mainly helpful for assessment of the ejection fraction. And stable angina and NSTEMI, in both of them there can be normal ejection fraction as well. Okay, so even this will not be useful to differentiate the stable angina from NSTEMI. So the best answer will be the cardiac biomarkers. Next question. So coronary artery disease, it is associated with all except chlamydia, poor dental hygiene, smoking, and as well as the alcohol. So the one which does not cause the coronary artery disease is the alcohol. Very, very important. See, alcohol, when it is taken in mild amounts, what is the recommended recommendation is like, what is the recommended levels in males? In males, the individuals can take 2 drinks per day. So in the sense like 230 ml per day. Whereas in females, the acceptable is 1 drink per day. So whenever the individual takes like in this limited quantities, then it has beneficial effect and there is lesser chances of development of coronary artery disease. But if the level beyond extent, definitely there will be leading to coronary artery disease. In chlamydia, poor dental hygiene and as well as smoking, all of them, they does cause the coronary artery disease. Next question. Which of the following is the best test for viable myocardium after myocardial infarction? Thallium scan, MUGA scan, MDCT, then stress echocardiography. So in order to assess the viable myocardium after myocardial infarction, the best test is the thallium scan. So thallium scan, it is a class 1 indication for, right? It's a class 1 indication for risk assessment, prognosis, and assessment of therapy after ST elevation acute myocardial infarction. Okay. And the another very important point is, right? So it's a class 1 indication for risk assessment, prognosis, and as well as assessment of therapy after ST elevation MI. And it helps to determine the LV function, presence or extent of the stress-induced ischemia, detection of the infarction size and residual viable myocardium. This is what is the importance of the thallium scan. It's a class 1 recommendation for these functions. All right. Next question. Which is the best for the plaque morphology? CCTA, MRI, optical coherence tomography, and intravascular ultrasonography, that is IVUS. The best for plaque morphology is the optical coherence tomography. So which is best is like OCT is best, then followed by that IVUS, which is an invasive procedure, then followed by that the CCTA. Okay, so this is like the order in which you will be able to assess the plaque morphology. All right, and what are the plaque morphologies which are at increased risk of the rupture and causing myocardial infarction? That includes the following. So presence of large plaque volume, low CT attenuation, napkin ring sign, positive remodeling, and spotty calcification, all these are associated with high risk of acute cardiovascular events in the patients. Okay, so these, they tell you that there is high risk of the acute cardiovascular events in the patient. Very, very important point. Okay, next. Moving to the next question. Which of the following is associated with atherosclerosis? Chlamydia trachomatis, pneumonia, psittaci, and then gingivitis or gingivalis. It is your chlamydia pneumonia which is associated with the development of atherosclerosis within the coronary artery, causing coronary artery disease, right? And chlamydia trachomatis associated with the sexually transmitted disease. Then chlamydia psittaci, it is associated with the psittacosis, which is also a lung pathology. All right, next question. Unstable angina is characterized by the decrescendo pattern on the symptoms, crescendo pain with ECG findings, ST segment elevation, normal cardiac biomarkers. See, unstable angina, you don't have decrescendo pattern of the symptoms, right? You have the crescendo pain with ECG changes. Now, what will be the ECG changes is there can be ST segment depression, and along with that there can be T wave inversion. So you have non-specific STT changes. That is what you will observe in case of the unstable angina. All right. Now, there are certain features of unstable angina, out of which minimum 3 should be there. So, right. Now, unstable angina is defined as angina pectoris or equivalent ischemic discomfort with at least one of the 3 features. Number 1, the pain should be at rest and the duration should be for nearly more than 10 minutes. And the pain should be very severe and it should be of new in onset and it should be progressing, right? Progressing in the sense like it should be crescendo pattern. Okay, so yeah, both of these are the same points. And third point is, in unstable angina, the STT changes like ST segment depression or like T wave inversion should be there. So out of these three, at least one should definitely be present to call it as the unstable angina. All right, next question. And so in this question, it should be like crescendo pain with the ECG changes. Next question is, Dressler syndrome is characterized by onset within 72 hours, treatment of choice is steroids, pericardial effusion, and angina. See, what is this Dressler syndrome is? Dressler syndrome, it is a post-myocardial infarction, pericarditis. And these patients, they are characterized by a triad. What will be the triad is the presence of the fever, then there will be pain, but the pain will not be like angina. It's a like pleuritic type of chest pain, where the pain increases on inspiration. Then on auscultation, there should be a pericardial friction rub. Right, there should be a pericardial friction rub, or there should be presence of the pericardial effusion. Right, there should be presence of the pericardial effusion. So this is what is the triad in case of the Dressler syndrome. So it is characterized by pericardial effusion and occurs within 72 hours is a wrong statement. It occurs after few days to weeks after myocardial infarction, right? And the treatment of choice is not steroids. We give the anti-inflammatory drugs, that is the aspirin should be given in high dose, right? Aspirin should be given in high dose, and if the pain does not subside, then you can give even colchicine. And angina will not be there. It will be like pleuritic type of chest pain. And what is the mechanism for the Dressler syndrome is, it is believed to be resulting from autoimmune inflammatory reaction to myocardial neoantigens which are formed as a result of the myocardial infarction. Okay, next question. The exercise testing is absolutely contraindicated in which one of the following? 1 week following myocardial infarction, unstable angina, symptomatic severe aortic stenosis, then peripheral vascular disease. Okay, so exercise testing is absolutely contraindicated in case of the symptomatic severe aortic stenosis, where the individual can develop an arrhythmia and causing a sudden cardiac death if a symptomatic patient is made to undergo the exercise testing. Whereas 1 week following MI, yes, the TMT can be done, but within 48 hours of myocardial infarction, the TMT is absolutely contraindicated, right? Unstable angina, okay, it can be, right? Again, it's a relative type of contraindication. Peripheral vascular disease, it is not an absolute contraindication. Okay, next question. Most important predictor of the coronary artery disease is VLDL, LDL, chylomicron, LDL to the HDL. So the answer is LDL to the HDL ratio. See, what is the optimal value? That is the normal value. The normal value is around 3.5:1. And maximum, how much is the desirable ratio? So the desirable ratio, it is around 5:1. And if the LDL to HDL ratio increases more than 5:1, then it's an important predictor of the coronary artery disease. Okay, so this is very, very important. Next question. All of the following arteries are common sites of occlusion except left anterior descending artery, right coronary artery, circumflex artery, marginal artery, which is also the branch of the right coronary artery. So if you see the occlusions, the most common vessel which is affected in the occlusion is left anterior descending artery, followed by that right coronary artery, followed by that the left circumflex artery. The one where the occlusion does not occur except, that will be your marginal artery. Okay, it is least common or does not occur at all. Okay, so but the most common will be LAD, left anterior descending artery. Next question. Streptokinase and urokinase are contraindicated in, see, wherever there is increased tendency of bleeding, you should not do this thrombolysis. Among the options, intracranial malignancy, pulmonary embolism, AV fistula, and then thrombophlebitis. So you take in case of intracranial malignancy, this malignant tissue, it is highly vascular, and whenever you do thrombolysis, this malignant tissue can rupture and there can be hemorrhagic stroke. So that is the reason why in intracranial malignancy, streptokinase and urokinase are absolutely contraindicated. Whereas in case of massive pulmonary embolism, where there is right ventricular failure and as well as the hypotension, then it's an indication for thrombolysis. And in AV fistula and as well as thrombophlebitis, they are not the contraindications for your streptokinase and urokinase. So the answer here is the intracranial malignancy. Next question. All of the following statements regarding subendocardial infarction are true except, the options are, these are multifocal in nature. These often result from hypotension or shock. Epicarditis is not seen. These may result in the aneurysm. So subendocardial infarction, why do they occur is, these often result from the hypotension or shock, and definitely they are like multifocal in nature. At multiple places you have this subendocardial infarction, and in case of your subendocardial infarction, right, in case of subendocardial infarction, epicarditis is not seen, okay, because it is the endocardium which is getting affected. And this may result from aneurysm. That is a wrong statement. When can you have aneurysm is, for suppose when there is full thickness infarction, right? So full thickness infarction means the transmural infarction. Okay, full thickness infarction means the transmural infarction. So that may result in the formation of the aneurysm. Okay, for aneurysm formation, full thickness infarction is required. Next question. Which of the following is not seen in the mitral valve prolapse? Transient ischemic attack, infective endocarditis, premature ventricular contractions, then defect in type 3 collagen. So mitral valve prolapse, it can cause transient ischemic attack. Transient ischemic attack occurs in MVP. That is mainly because of the endothelial disruption. Right? Because of the endothelial disruption that can lead to the cerebral emboli. Right? That can lead to cerebral emboli. Okay. Then you take infective endocarditis. Infective endocarditis, it occurs in case of the mitral valve prolapse. Okay. Because mitral valve prolapse will lead to mitral regurgitation. So MVP with MR, there is development of the infective endocarditis. Next, premature ventricular contractures. This can be seen. Why is that? Because of the stress which is exerted by the papillary muscles on the myocardium, that can lead to the development of the premature ventricular contractures and as well as the paroxysmal supraventricular tachycardia, right? And you don't have defect in the type 4 collagen, right? So defect in case of mitral valve prolapse will be in the type 3 collagen. Okay, so in type 3 collagen, like type 3 collagen is defective in case of the mitral valve prolapse. And what is the type of inheritance of the mitral valve prolapse is the autosomal dominant type of inheritance with incomplete penetrance is seen in patients with the mitral valve prolapse. Next question. Hockey stick appearance in echocardiography is a feature of the mitral stenosis, mitral incompetence, aortic stenosis, aortic regurgitation. So hockey stick appearance in echocardiography, that is due to restricted mobility of, right, restricted mobility of the anterior mitral leaflet. Okay, so that is what will be responsible for the hockey stick appearance, right? That is in the 2D echo. Whereas if you take the hockey stick appearance in the ECG, that is seen in cases of digoxin effect. And this hockey stick appearance in the ECG of digoxin effect, this is also called as the inverted moustache sign, right? And this is also called as the Salvador Dali sign, right? Or this is also called as the inverted tick sign. These are the various names given for the digoxin effect ECG changes. But 2D echo like hockey stick sign, you see that in case of the mitral stenosis. Next question. What is a murmur which is heard in aortic stenosis? That is, second right intercostal space low pitched, apex low pitched, left sternal area low pitched, pansystolic murmur high pitched. So in aortic stenosis, the murmur is heard in the right second intercostal space, which is nothing but the aortic area, right? And it is a low pitched murmur, right? So it is like low to medium pitch, right? It is low to the medium pitch. And what will be the character of this murmur of aortic stenosis? So it is rasping or harsh in character, right? It is rasping or harsh in character. Okay, and the murmur of the aortic stenosis, that will be radiating to the carotids, right? That will be radiating to the carotids. And the character, I mean, if you see the shape of the murmur or configuration of the murmur in aortic stenosis, it is crescendo and then decrescendo murmur. That is what you will have in case of the aortic stenosis, crescendo decrescendo configuration. And coming to the apex low pitched murmur, right? So you take mid diastolic murmur of the mitral stenosis, it is heard at the apex and it's a low pitched murmur. And next is pansystolic murmur, high pitched. That is in case of MR, you have pansystolic murmur and that too high pitched. Okay. And in aortic stenosis, you also need to remember one important phenomena called Galliverdin phenomena. So Galliverdin phenomena is that where the murmur of the aortic stenosis, that will be radiating to the apex. That is called as the Galliverdin phenomena. All right. Next question. Durose's sign is seen in the AR, AS, MS, MR. So Durose's sign, it is a sign in case of the aortic regurgitation. So what is that you need to do in 𝗠𝐸𝐳𝐫𝐞 sign is you need to place the stent over the femoral artery, and when you compress the stent proximally, then you listen a systolic murmur, and when you compress the stent distally, then you will have a diastolic murmur. Okay, so this systolic murmur and diastolic murmur together, this is what is called as the 𝗠𝐸𝐳𝐫𝐞 sign. Right, together this is called as the 𝗠𝐸𝐳𝐫𝐞 sign. Okay, next question. Which of the following is the cause of the white pulse pressure, right? Which is nothing but difference between systolic and diastolic blood pressure. Aortic stenosis, aortic regurgitation, mitral stenosis and mitral regurgitation. Okay, so the answer is pretty easy, that is aortic regurgitation. But in case of aortic stenosis, how will be the pulse pressure? It will be the narrow pulse pressure you will have in case of the aortic stenosis. But I just want to tell you what are the various other causes of the white pulse pressure. So white pulse pressure, you can also have that in all the hyperkinetic states. Okay, so what are those hyperkinetic states? The hyperkinetic states that includes like fever, anemia, pregnancy, anxiety, thyrotoxicosis. In all these conditions you can have white pulse pressure. Then atherosclerosis, you can have the white pulse pressure. Then in case of the aortic dissection, you can have the white pulse pressure. And in cases of raised intracranial tension or intracranial pressure, you can have the white pulse pressure. Okay, so the answer in this question is A. Next, I'm sorry, the answer in this question is B, aortic regurgitation. So if you see the next question, in mitral stenosis, double density or double atrial shadow is due to enlargement of right atrium, left atrium, both atria, left auricle. So the answer is the left atrium, right? And this is what is the X-ray of the double density sign. See, normally this is your left atrial border, which is usually not seen. Why? Because it is present in the retrosternal area. So left atrial shadow is not observed normally, right? Whereas you take in case of the mitral stenosis, you are having the left atrial shadow and the other one is the right atrial shadow, and this is what is called as the double density sign, right? Normally what you observe is only the right atrial shadow. Next question. The pulsatile liver is seen in tricuspid regurgitation, tricuspid stenosis, dilated cardiomyopathy, pulmonic stenosis. So pulsatile liver, it is seen in case of tricuspid regurgitation. See, in tricuspid regurgitation, the blood from the RV will be regurgitating back into RA, okay, during the systole. So the blood from the RV which has been regurgitated into RA during the systole, that will be transmitted to the liver, right? These pulsations will be transmitted to the liver, and this will give rise to the systolic pulsations, right? This will give rise to systolic pulsations. So that is what is nothing but your TR. All right, next. So a patient with angina, exertional syncope, left ventricular hypertrophy is diagnosed to have aortic stenosis. What is the predicted lifespan of this patient? 1, 2, 3 and 4 years. So in individual with angina and as well as the exertional syncopal attack, the predicted lifespan, that is nearly around 3 years, right? Whereas if the patient is having the dyspnea, then the predicted lifespan is just 2 years. And if the patient is having the congestive heart failure, the predicted lifespan, it is around 1.5 years. Okay, so the answer in this question is C, that is 3 years. Next. Displacement of the cardiac apex to left and downwards indicate right ventricular hypertrophy, left ventricular hypertrophy, right atrial hypertrophy, left atrial hypertrophy. So displacement of the cardiac apex to the left and down, it indicates the left ventricular hypertrophy. Whereas you take in case of the right ventricular hypertrophy. In right ventricular hypertrophy, the apex, it is shifted to the left and upwards. That is what you will observe in case of the right ventricular hypertrophy. Okay. And in right atrial or left atrial hypertrophy, you don't have shift in the cardiac apex. Next question. So dyspnea, syncopal attack, angina occurs most commonly in MS, AS, MR and then AR. So the answer in this question is the aortic stenosis. In aortic stenosis, just remember this mnemonic SAD. Okay, so SAD stands for syncopal attack, then angina, then dyspnea, right? Then dyspnea. Okay, so this is what is your SAD, which occurs in patients with the aortic stenosis. Whereas you take in patients with mitral stenosis, these patients usually they develop dyspnea because of pulmonary edema, and they can also have palpitations, and that is because of the atrial fibrillation. Whereas in MR and AR, these patients they present with palpitations, right? And followed by the palpitations, the next important symptomatology will be dyspnea, and that is because of left ventricular failure. So the answer in this question is the AS, that is aortic stenosis. Next question. Most common valvular lesion seen in the carcinoid syndrome is, so okay, tricuspid stenosis and pulmonic stenosis, tricuspid insufficiency and pulmonic stenosis, mitral stenosis and aortic stenosis, mitral insufficiency and aortic stenosis. So in carcinoid syndrome, it is the right-sided valves which are commonly affected, and it is a condition which is characterized by excessive production of the serotonin. Just remember this mnemonic TIPS in case of carcinoid syndrome. What does this TIP stands for? Tricuspid insufficiency, which is nothing but tricuspid regurgitation. Then PS stands for the pulmonic stenosis. Okay. So this is what is called carcinoid heart, right? So this carcinoid heart, it results from the neoplasms of the enterochromaffin cells. Okay. It's a neoplasm of the enterochromaffin cells. Okay. Next question. All of the following statements about the mitral valve prolapse are true except it occurs more commonly in females. Most patients are symptomatic. It's a benign clinical course. Transient cerebral ischemia is a known complication. So this is a true statement because it is the one which is more commonly seen in females rather than males. And it has a benign course, right? And transient cerebral ischemia can occur. Why is that? That is because of the rupture of the endothelium or endothelial dysfunction, where there can be formation of the vegetations, and that can shower the emboli into the cerebral circulation, causing TIA. But most patients are symptomatic is a wrong statement. Most of these patients with mitral valve prolapse, they are asymptomatic, right? And the next very important point in mitral valve prolapse is what is the drug of choice, if at all, if they are symptomatic. So the drug of choice will be the beta blockers. Okay, and the other complications apart from transient cerebral ischemia are that also includes, right? That also includes like the arrhythmias. What will be that arrhythmias? Premature ventricular contractures or the paroxysmal supraventricular tachycardias. All right. So the answer here is most patients are symptomatic. That's a wrong statement. Next. Angina pectoris and syncope are most likely to be associated with mitral stenosis, aortic stenosis, mitral regurgitation, tricuspid stenosis. So angina pectoris and as well as syncope, just now as we have discussed, it is most commonly associated with the aortic stenosis. Next question. LVH is commonly seen in pure mitral stenosis, ASD with fossa ovalis, the aortic incompetence, and then carcinoid syndrome. See, LVH is seen in case of the aortic incompetence is nothing but aortic regurgitation. So in aortic regurgitation, you will have volume overload resulting in left ventricular hypertrophy, where the apex is shifted down and as well as out, right? Down and as well as out, because it's a volume overload condition. Whereas in mitral stenosis, there is no LVH at all. So except the left ventricle, all other chambers like left atrium, right ventricle and right atria is affected in case of MS. And in case of ASD, you have the right ventricular hypertrophy but not left ventricular hypertrophy. And same is even in your carcinoid syndrome also, where you have the right ventricular hypertrophy, and that is because of the pulmonary stenosis. All right, next question. So here the answer is aortic incompetence. So the last question, obstruction in the pulmonary stenosis may occur at the following sites: supravalvular, valvular, subvalvular, all the above. In pulmonary stenosis, the obstruction can happen at any place, either supravalvular, all valvular, or subvalvular, all the above. So this is about Medicine Challenge Day 5, where you have the questions related to cardiology. And tomorrow again, that is Day 6 Medicine Challenge. So please attend that on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, where it becomes very easy for you for planning and as well as completion of the general medicine thoroughly and easily. Thank you very much.